All right, hello everyone, and welcome to this DHN Town Hall. For decades, the story of Indian healthcare has followed a very simple script. A patient falls ill, walks into a hospital, and gets treated, and walks out until the next time something goes wrong. That's the episodic care. It's reactive by design, and it has worked for a long time. But the ground is shifting, chronic conditions are rising, patients are living with multiple comorbidities over decades, and outcomes are increasingly being judged not by what happens inside the hospital, but by what happens after the patient leaves the hospital. Do they stick to their medication? Do they return for follow up? Do they relapse? That's a game episodic care was never built to play. So today's question is direct and very essential. Is Indian healthcare actually ready to move from episodic care to continuous care, which is also AI powered? And can AI genuinely get us there, or is this still more promise than practice? Over the next 60 minutes, we will dig into what continuous care really means on the ground, unlocking EMR data for personalized patient journeys, what FHR native interoperability actually takes to implement, and how artificial intelligence is helping reduce drop offs and improve adherence. What hospital leadership needs to prioritize starting now, not 5 years from now. To help us answer that, we have brought together some of the sharpest clinical and operational minds in Indian healthcare, along with the innovator building the technology itself. Happy to introduce our speakers for today. Let me introduce our panel: Dr. Nandkumar Jairam, former chairman of Columbia Asia Hospitals and one of the most respected voices in Indian hospital leadership. With decades of experience steering multi hospital operations through exactly this kind of structural transformation. Thank you so much, Dr. Jairam, for joining us today.
Most welcome.
Let me introduce our next speaker, Dr. Shuchin Bajaj, founder and director of Ujala Cygnus Hospital, who has built a hospital network from the ground up with a strong focus on accessible, scalable care delivery models. Thank you so much, sir, for joining us today.
Thank you very much. It's such a pleasure to be here.
Next set of leaders are operators, Dr. Shashi Pawar, Chief Operating Officers of Kokilaben Dhirubhai Ambani Hospital, bringing a frontline operational lens on what it takes to run continuous care at one of India's most advanced tertiary care institution. And Mr. Saurabh Gupta, Regional Director at KIMS Hospital, with deep insight into scaling patient engagement and care continuity across large multi-specialty network. Thank you so much, both of you, for joining us here today.
Thank you, Aarti.
And the next speaker is Mr. Asit Kumar Vidyarthi. Our sponsors for today, partners for today, this entire town hall is powered by Prodoc AI, and one of the companies that is solving this problem of episodic to continuous care. Co-founder and CEO of Prodoc AI. Thank you so much, Asit ji, for joining us here today.
Thank you, Aarti. Thank you very much.
We have one more speaker joining us in a short while. In the meantime, we will start with the questions today. My first question is directed to Dr. Nandkumar Jairam. Dr. Jairam, you have led hospital systems through several eras of Indian healthcare. You have seen the transformation that has happened, right from the paper-based to paperless hospitals. Why has the episodic walk-in, walk-out model persisted this long, and what's finally forcing the shift now? Your thoughts?
Well, you're right, Aarti. I've seen healthcare change tremendously over the last 50 years. When I started practice, we had only a pen and a stethoscope. We did not have any technology. And then we progressed to technology and used technology to improve the quality of our diagnosis and the quality of our treatment. Throughout this period, episodic was the only way in which healthcare was delivered, and the clinician knew to deliver healthcare only in this fashion. There was no concept of continuous care because that simply did not exist, nor did anything like AI ever come to the minds of people at that point, not even, say, 5 to 6 years ago. So it's a very recent trend and a welcome trend at that. But that is the main reason why we followed episodic care all along until now.
Dr. Nandkumar Jairam, adding on to that, I would like to ask you, a follow-up question to that. Today, we are seeing there are a lot of AI solutions in the market, and there is a lot more tendency also to adopt these AI solutions. But Still, the adoption remains the major challenge. What do you think the single biggest organizational or cultural barrier a hospital leadership faces in moving to a continuous care mindset?
Well, I would hazard by saying there isn't one single factor really, but I'll list some of the factors starting with the most important first. Clinicians' reluctance to accept artificial intelligence as a proponent of healthcare or deliverer of healthcare is the main reason why this is not where it should be. Also, there is a question of accountability in AI, which is another reason, and lack of regulation. And these are some of the reasons why it has not come in. However, I would add to this that failure to adopt EMR, which is one of the big important bricks that builds the stone of uh, healthcare in artificial intelligence and continuous care, is not yet there. And so these are the reasons by which I would say we have not reached where continuous care should be.
Right. Since we are talking about the adoption of EMR, which largely remains, absent in the Indian healthcare, let me point my next question to Dr. Shuchin Bajaj. Uh, Dr. Bajaj, Ujala Cygnus operates largely in tier 2 and tier 3 markets. And this is the also market where you see the adoption of EMR is very less. For a market like that, what does continuous AI powered care realistically look like, especially since these are also resource constrained settings versus a large metro hospital which has all the resources to deploy EMR, deploy new solutions, pilot solutions, etc.
First of all, thank you very much, Aarti, for having us here. And DHN, we've seen, has been, over the last few years, always been leading good and at the same time difficult conversations, but very important conversations. So thank you for keeping at it. And thank you to Asit as well for getting us all together, and also for, as a conflict of interest disclosure, also for driving a lot of these things for us. So thank you very much. See, I think the biggest misconception, and most panelists would agree with me here, is that I don't think continuous care requires expensive technology, right? I don't think it requires big city level of adoption. In our experience, I think it requires the right workflows more than more sophisticated tools, right? We work in semi-urban, rural, small town ecosystems, and our patients often travel long distances, right? And they lose their daily wages. Just taking a day off to come to the hospital means that you may not have food to eat when you go back, right? That is the situation many of our patients have. And even if you run free hospitals in these towns, getting into the hospital sometimes is too expensive for the community to afford. So they will not return unless there is a very compelling reason for them to come. Right? It is too expensive for them. So I think what we need to solve for, and what AI needs to solve for along with us, is very practical problem, right? We need to identify which diabetic patient has missed a follow-up. We need to remind a cardiac patient about missed medications. We have to flag the abnormal results that need an immediate attention, that we need to call the patient back and say something is really wrong. We need to really prioritize which patient the doctor speaks to and calls, right? That is what we need to do. So we don't need AI replacing clinicians at all. We need, AI making clinicians more effective, ensuring that no patient is falling through the cracks. And sometimes there are advantages also of resource constraint setting, like, because how did we make this lean model? Because I was in a resource constraint setting, I had no resources, so I did not follow the traditional path ki zameen kharido, hospital banao, ek hospital bada sa karte jao. I had no money to do that. So this whole lean model of leased buildings, low cost hospitals came out of the fact. So I think sometimes we are advantageous in that we are often more agile. We don't have decades of legacy systems. We don't have this, standard protocol sometimes to follow. If solutions are simple, interoperable, mobile first, I think we can implement them much faster than most large institutions. So I think for me, continuous care is not about expensive technology. It's not
Hmm.
about more hospital visits. It's not about repeated care. It is about keeping patients healthier between the hospital visits. If AI can reduce preventable admissions, if it can improve adherence, if it can detect deterioration earlier, if it can prevent complications, that is the real value. It doesn't really matter how much expensive technology you use for that. And I think what we are experiencing right now with a lot of help from organizations like Prodoc is something that will definitely help us keep patients out of hospital as much as possible.
Right. I think three threads from the your responses. One is uh, patient's trust is also tied to the doctors. Secondly, even though the hospitals in tier 2 and tier 3 markets are resource constrained, that doesn't mean that innovation doesn't happen there. They are more agile. And the third factor that I think that came out of your response is that continuous AI powered care does not really mean repeated patient visit. It means that healthier patient. But taking a cue from the first factor was that patient trust is tied to generally doctors, especially in Indian setting. So in such a situation, how do you build patient trust for a continuous care journey, especially when most patients are sort of also conditioned to think of a hospital visit as a one-time transaction and also tied to the doctor trust?
No, I absolutely agree with you, Aarti, that patient trust is hugely built upon human interactions, doctor interactions, nurses. It starts from the way a security guard greets you when you enter the building, right? So trust is built long before technology comes into the picture. Our patients don't continue with us because we send them reminders on their phone or we send them, these flags and everything. They continue because they truly believe someone genuinely cares about their health. Once they've left the hospital, once they're in the hospital, if they believe that we are truly genuinely concerned about them, that is where trust builds up, right? And this starts with the treating doctor explaining that recovery doesn't end at discharge, right? We reinforce that through follow-up calls, through medication reminders, through health educators speaking to them, through our community outreach programs like Sehat Chopals, where we go to their village, we speak to them again, we make them speak to the rest of the village that I went to the hospital, this happened with me, this happened, now I'm better, earlier I had this problem. So these tools make the connection easy and make the trust building exercise much more reliable when it is done repetitively and much more faster compared to the first patient where you build the trust. Using those patients to build trust for you is much more simpler, right? And then you just supplement it with those digital tools and reminders. And
True.
I think more importantly, every interaction that happens, whether it is physical, whether it is digital, it should provide value, right? It should not be valueless for either of the two parties, right? I should not think that it is value for me. I am sending you a reminder, please come to OPD on this date.
Hmm.
That is creating value for me, that okay, I am getting a follow up back. But
True.
is it really creating a value for you? You are just
Hmm.
getting a reminder, please come. Why should you come? You're like, भाई मेरे तो पैसे नहीं कमाने, मेरी नौकरी छोड़ के मैं क्यों जाऊंगा उधर, है ना? तो मेरे तो बहुत काम है. So if
Hmm.
every phone call or every SMS is simply about this, that please come to hospital on this date, they will stop answering. They will
Hmm.
not reply to you. They will ignore you. Maybe they'll block you, right? But
Correct.
if that call helps them to manage their diabetes better, it helps them to adjust their medications, to reduce their medications, to avoid complications, to make them feel better, then that trust grows automatically. Then you don't really need to work on it a lot, right? So
Correct.
it works naturally. So technology enables continuity, but I think empathy creates that continuity. So empathy and technology have to work together. AI can tell me who needs the attention. That this patient has missed, this patient is complicating, this patient has bad reports. So AI can tell me who needs that attention, but I think my people, or when we train the AI enough, that can only build the lasting relationship. So both have to work together a lot.
True, I think that very well said, Dr. Bajaj. Because empathy and technology, when they work together, that is only when we create true value for the patients, and not just through continuous reminders. One of the point Dr. Jaikumar mentioned was about EMR compliances and the EMR adoption in hospitals. Let me just quickly go back to that thread, because I think that is also one of the important factors, because the patient engagement sits on top of EMR and the basic foundations of these hospital management systems. Dr. Shashikant Pawar, I would like to come to you. Any hospital in India today, you see, it generates enormous amount of EMR data every day. What is actually stopping that data from being turned into a personalized, proactive patient journey? Is it technology? Is it process? Or is it the mindset of the leadership that is sort of being a hindrance into the same?
First of all, thank you for having me here for the panel discussion, Aarti, and thanks to DHN for arranging such a beautiful panel discussion. It's quite practical question which you have put across to us, and as we have been discussing about the EMR, you're right. A lot of data is getting generated in terms of reports, medical records, lab reports. You can say or diagnostics. But as I said, the interoperability between the two, various systems are working in the hospital. Maybe in the labs, what we call ACT system for the imaging, all those data don't get collated at one level. The IP
Hmm.
file, or you can say the EMR, what we call, is just a document where we are able to connect and we are able to access within the hospital of that given domain. Or maybe, if it is a chain of hospitals, if they have a common server or something, they are able to do that. But if I want to know at a remote level for a patient longevity, or the I say that chronology of the records has to be maintained. For example, sir was saying about a diabetic patient, or maybe a liver failure patient, or maybe a kidney failure patient. They will be requiring a repetitive visits, and what has been happened, or commonly it is in the oncology cases where the case goes on maybe for 4 years, 5 years. After that, they have a radiation, they have the surgery, all those are there. But what happens is we don't have in India at such a common platform where this can be accessed. For example, you can have some kind of a digital login or something, which I believe now the government is going into, like an ABHA program, where you have your own health login something number, and then you can access all the data or the records possibly when you are able to make it available on that platform, and that is not happening as of now today. Plus, if you talk about imaging and the lab report integrity, integration rather, with that system is still not established, which I believe, right? So this is something, a deficit or a gap, which I would like to point out, where the technology certainly is going to help out for going further, and the compliances maybe from the hospital will help us, and the patient of course has to give the consent that it can be uploaded there, and the accessibility can be there wherever he goes, maybe not in Maharashtra, any part of India also, if he goes, be able to access it. And the doctor who's treating has an access to the whole chronology of the records, what he has been through, what were his, the sugar levels maybe 2 years back, what interventions has been undergone, now presently what has resulted for a better care for the patient. So this is what I believe is a little bit of gap which can be there as far as the technology part is concerned. Yes. And second thing, as I said, the acceptability, the mindset of the patient itself is also there. How do I use the applications? If I'm starting an apps also in a mobile app right now, I'm just little diverting on a part of that part. Maybe we talk about OP records. The OP record itself is also an EMR, what we call about. So they are very like episodic, commonly kept. These also has to be kept in a chronology, like what I've shown in the OPD, what were my records at that time. So that can be collated and kept in the app also nowadays, because there's a lot of cloud servers available. So then once the patient also adopts that level of technology, it becomes two-way for us to be able to deliver a better care to the patient in that terms. Thank
Right, right. One of the, I think, takeaway from the response of Dr. Shashikant is the fact that all these technologies are operating in silos. You know, your OPD, your EMR, they are storing data. Your medical devices are storing data. There's a separate, data is generated in your diagnostic process. But what is missing is the interoperable layer, and I think we have been talking about it time and again. From the technology side, and Asit, I want to ask this question to you. What do you think is the real barrier to interoperability across Indian hospital today? And the fact that even for a patient to view his longitudinal record, it becomes a difficult task. What is the hindrance? Is it the standards? Is it the incentives? Or just sheer willingness to adopt the newer technologies?
See,
Yeah,
first is the
thank you.
uniformity. You're asking me, ma'am?
Shashikant ji, if you want to add to that, please
Yeah.
do add, and then I'll move to Asit.
The question is to me, right?
Shashikant ji, yes, you can proceed.
Yeah. As I said, the uniformity of the care may possibly the standardization, which I talk about, is generally different from the different hospitals in Indian care scenario as of now today. If you look at the UK base or the NHS, they may have a one standardization way of it. So that is the reason possibly where the gap comes of interoperability, as you said, between the systems. Yeah, I think you have asked question. You can proceed ahead on that.
Yes, Asit ji, please, over to you.
Yeah, thank you, Aarti. Firstly, thank you, DHN, for setting such an amazing panel. We have experiences across fields and people with, I think, covering the entire spectrum of healthcare. Yeah, now getting back to the question, I think standards and the foundation is kind of already set today. You have FHRI, ABDM, all of them, the foundation is already in place. What we have seen as a technology, the real barrier is how can the aligning of technology be aligned to the hospital priorities, right? Many organizations still believe that interoperability is an IT project, whereas it's more of a business transformation initiative. In fact, if you realize when hospitals realize that the connected data can improve patient outcomes, it can reduce operational efficiency and create new revenue opportunities through better continuity of care, adoption will become much faster. And this is where we have seen as technology companies where the IT team has become a part of the CXO level team, right? They are becoming a part of the business decisions. We have seen the adaptability of technology, the IT solutions much better in those kind of hospital setups.
Right, right. Also, Mr. Asit, one of the factor of continuity of care is what also actually happens between the care visits, right? The episodic care ensures that the patient visits the hospital when the patient is ill, when the patient is sick, then he goes back home, then he comes back when, he's feeling sick again. What happens between that is also the important factor into this. How do you think an EMR connected AI layer actually change what care team can do between the visits and not just during them?
Oh, this is amazing. So what I'll do is I'll bring up both the points with Dr. Jairam sir has said and what Dr. Bajaj sir has put it, right? Firstly, EMR is kind of the central theme of the whole. The biggest challenge is how you get data inside the EMR, and that's the base of everything in terms of having an platform set above that. So the first thing that actually starts, I think it should be the AI scribing. Because the biggest challenge that we see today is how do you feed data inside EMR, right? And it has to capture across various segments. And what the healthcare professional wants is they want to kind of have more time with the patient rather than generating data. So a thing like AI scribing can actually create the entire data capturing right from the first step of the patient coming inside the hospital, which is the OPD thing, right? So
Right.
that leaves the first part. The real value actually begins when the patient leaves the hospital. Now, because UMR now has a continuous, structured, additional, actionable information, right? it just cannot just be like for a reminder, अरे next appointment आपका यह है आप आ जाओ. As Dr. Bajaj rightly said, it has to be more on the empathy part. Now that you know if somebody has missed an appointment, the AI can actually trigger a call or saying that you have missed an appointment, hope you're doing well, right? It shouldn't just be about making sure that the patient comes back to her hospital.
Hmm.
There are times where for certain days a patient has to start, say post-operative, right? He has to start with a physiotherapy. So if the AI is able to generate that particular call, that okay, fine, now it's time for you to start your physiotherapy. So if you have missed medication, remind them about medication. So create that empathy, and that is all happening because you have already structured, created an intelligence layer above an EMR and all the channels in which the patient's data is collected. Right? A very simple thing. If somebody now the AI can actually trigger a red flag if for a particular patient who can be at risk if there is not a follow-up done. Right? That is kind of a thing that a solution like AI can bring that particular part. So for us, if you look at the EMR that you have, right, it just tells you what has happened in the hospital. The AI is the next step. It will tell you what can be done thereafter.
Right. Very well said, Mr. Asit, on this part. So far, we have heard about the need for the shift from traditional episodic care model to the modern continuous care journey. We have also heard about the data and interoperability problem in the Indian healthcare ecosystem and how continuous care will actually benefit from the interoperable layer in Indian healthcare ecosystem. However, the adoption of technology is one of the major concerns in Indian healthcare, and why hospitals are sort of reluctant to adopt technology is the reason why we are also going to enter into our segment 3, which will focus on the ROI part of it. AI and newer technologies, patient engagement technologies, have immense promises, but what happens when it comes to the ROI part of it? Is AI actually reducing drop off and improving re engagement? And what is the ROI that follows it? For my next question, I would like to go to Mr. Saurabh Gupta. What real world results have you seen when a hospital shifts from reactive care to proactive patient engagement? And anything you can sort of put a number to?
So, Arti, thank you, and thank you, DHN, for such a thought-provoking town hall. So, I was actually thinking about the shift from non-communicable diseases to shift from continue this episodic care. My bad, to continuous care. And I just happened to read one data which is actually quite relevant. I was looking at the estimated proportion of deaths in 1990 from non-communicable and lifestyle diseases. It was around 37% of all the deaths, but in 2016 it rose to 62%. Now that single data itself tells you the entire story. Why everybody suddenly is now AI came later, but why suddenly everybody is talking about non-communicable disease and lifestyle diseases? Because that needs continuous care. So that was my thought process. Now, when we talk about the financial ROI, see, we started long time back with digital marketing and digital healthcare. Now, time has come when you have uh, very established parameters for digital ROI. However, in case of AI and any of the products like you those dog stripe, we have Prodoc, which is working very well, and others. It is more of a proof of concept in many hospitals. Of course, I will show and talk about some numbers, but exact financial ROI we are yet to see. And throughout the industry, there are multiple products being used, and some of them have shown considerable improvements, um, even financially. So the first thing is, when we talk about any product which is an AI based or a digital healthcare tool, we should look at three aspects. One is the clinical outcomes. The second would be the patient experience and business performance. When we talk about the clinical outcomes, what we have seen in some of the hospitals which we have used, and in fact, I must share that some of our hospitals, which are in tier 2 and tier 3 towns, are 100% paperless. So there is a hospital in Anandpur, which is now being converted into a 500-bedded hospital. Anandpur is actually a tier 3 town in Andhra Pradesh. It's a 100% paperless hospital, truly running on EMR. We have our own EMR and other systems. So it's again going back to what Dr. Bajaj said, that you need not have a metro and full-fledged system or a big city to actually get into meaningless digital IT integration. You can do it in tier 2 cities and tier 3 cities, and some of our hospitals have done it. So in some of our hospitals, what has happened is that the no-show rate, in the OPD, because of the reminders and rescheduling, has gone down from it used to be like 30 to 40% no-show. Now it is only 20%. So around 20% of the no-show has dropped. Now it has a significant improvement in the slot availability and also adds to the revenue. So it's a business performance. When it comes to the clinical outcomes, there is a hospital which is I cannot name the product, but it is using some of the IT tools. But the readmission rate, because of the reminders and telling what needs to be done, especially after an episode, like if somebody has myocardial infarction, went for angioplasty and then gone home. So what needs to be done? The readmission rate has gone, reduced by almost 15 to 18% in one of the hospitals. And also, when we talk about the patient experience, what we have seen is that the NPS score. So we actually have a standard of around 75 to 80% NPS minimum. So the NPS scores have improved by 10 to 15 basis points. So that's what we have seen. We have also seen that the repeat visits have increased because there is a constant follow up. And I'm sure all the major hospital groups, be it in tier 2 and tier 3 cities, have been using it. And I think very soon we will have industry standards on what is established ROI. But as of now, what we have seen is uh, there are very good proof of concepts in all the three domains, whether it's clinical outcome, patient experience, or improving business performance. And more importantly, reducing the disease burden on the entire society. So that's my take on it.
Right. Thank you, Mr. Saurabh. I think these are quite interesting statistics, and I think the entire panel might be focusing on this part as well. We are joined by Mr. Mahendra Pala, Group Chief Operating Officer of Omega Hospitals. Thank you so much, sir, for joining us here. And I think Mr. Pala brings a very important perspective into this conversation because he is operating a cancer care chain where continuity is not just about better engagement, better follow up with the patient. A simple missed cycle or a delayed follow up can change a patient's outcome. uh, Mr. Pala, as Omega scales across multiple centers, where have you seen AI meaningfully cut drop offs during something as demanding as chemotherapy or radiation cycle? And where do you think it has fallen short of what was promised?
Delayed, stuck with some other inspections. Uh, and I would like to thank DHN team for this powerful forum. Uh, so before I answer the question asked by Aarti, so I would like to make a statement. Today, the question is no longer should we adopt AI. It is more of how fast can we govern it responsibly and integrate it meaningfully. So when you say Arti, where AI is meaningfully drop off, so basically cancer care is fundamentally continuous. It's not episodic. A
Correct.
missed cycle doesn't mean that doesn't mean that there's a scheduling inconvenience. It is more of a clinical event. Okay, so the places where AI is what do you say is actually moved the needle on continuity is on the friction from decision making to the treatment accuracy. Okay, so I would like to share a couple of examples from our own centers. So, for example, the AI assisted PET MR, we have acquired one of the first of its kind digital PET MR in the country. So, our nuclear medicine consultants here, they report all the PET MRI scans. But out of this, the only complex cases are reported and are run through AI also. So what happens? So what is the outcome of this? So it is creating a built-in second opinion that speeds up complicated case, the turnaround, and it gives specialist confidence, and also more important, the patient reassurance, patient visible reassurance, so that there are two independent reads agree. So significantly, this minimizes the delay between the imaging and the next treatment decision. The second experience I would like to share is about the kind of linear accelerator machine what we have. Again, it's a AI based. We term it as adaptive radiation therapy. So a patient anatomy on day 15 is different from the day one, and the tumors might shrink, or weight can drop, or organs can shift. But here, AI here analyzes the day scan, re-identifies the tumor and nearby organ boundaries also, and thus it adapts itself and proposes an updated plan on the real time when it is on the couch. So this keeps the plan very honest to what's exactly is happening on the patient's body, which matters directly for continuity. So a priority adapted plan is one of the most important reason, and one of the most important reason cycles which get paused. Okay, so one more example I would like to quote on the pathology AI. Today, the pathology AI, it analyzes the biopsies much faster and consistently also. Okay, so the common thread about this digital PET and linear action with AI based and pathology AI is, so all these AI tools what we use at Omega are minimizing the time between what do you say, the assessment and the clinical execution. So whether it's a scan being read, or a plan being adapted, or a biopsy being analyzed. So the value isn't the AI output itself. It minimizes the time frame between assessment and the clinical execution. So that's what
Right.
my take on that. And you also spoke about the second part of the question was where it falls short, what we plan. So okay, so the gap is most drop off in cancer care isn't a clinical decision problem. It is a logistics. It can be a cost. It can be a giver supporter. It can be fatigue. So there are multiple things. So AI-based clinical tools don't touch any of these things. So the my concluding point would be the AI has strengthened the clinical element of continuity by compressing the assessment to execution time, whether it is imaging, planning, or pathology. But continuity has
I think Mahendra sir's screen is frozen. I would like to invite our panelists from clinicians' voices as well as operating lenses voices to add to this conversation.
As I say, we look forward AI as an enabler and should not be a roadblock. That's where it comes. Like it should be an adoptable, or acceptance is the first thing. That as the era progresses, the doctors, whoever the paramedics, has to know that we need to adopt the change in the technology and go forward onto it. So basically, what we look at is the adoption and the implementation of this AI, and it should look upon as an integration between the human intelligence as well as a technology. So we call it like it will enable the doctor to be more accurate, more specific, more fast doing the repetitive task. Diagnosis could be more faster. So rather than the AI has its own difficulty is mainly is the acceptability by the user. That is what I feel. So once we are open-minded about it, as we have been progressed, if I look at an example, a simple example, that it's something not to be apprehensive about. Like we have evolved over a period of time in this era of medical field, where we started with the stethoscope, then the X-ray came, then the CT scan came. It is nothing a new thing which will be coming. Your mobiles have evolved from a simple phone to a smartphone as on today. It's obviously an AI tool is something which will enable us to give the patient care more better. So basically, as I said, the barrier could be only the acceptability to change, adopt, and implement to the bilaterally, not only the patient, but as well as the doctors or the paramedics who are involved into it. Because the patient, even if you tell them you do a remote monitoring using this device, possibly there is a factor of economy also. Cost factor may be there. He may not want to adopt that technology because he has to put the cost to it. Possibly that. But
Correct.
yes, it is very easy for us. It is going to be the future. We say it is the future, but it has already landed. It has started. If you look at the Western countries, they have already progressed too far. We are still behind at some level. It's not like undermining our own system, but yes, we are still yet to go about to it. And this should be the progress when way ahead towards it, and the approach should be there. And mainly the data. As I said, data is something which is AI ka main obstacle which I feel is data also. The second point which I wanted to make it up here is to the panelist and the listener is, the richest person which we call is having a data with them. Unless it is an accurate, because AI will only give you when we feed the data correctly to it. Otherwise, AI is not going to do anything. Unless we give an
Right.
accurate, seamless, and correct data, it is not going to. So, as we said, this is what going to be the hindrance if we are not ready with the data interoperability towards the AI tools what we are going to use. Thank you.
Correct. Dr. Jairam, if you want to respond to that, one of the major aspect is also the quality of the data that we feed to artificial intelligence. Otherwise, it is just garbage in, garbage out. If you want to respond to that aspect, what do you think is the sort of where AI sort of falls short in the Indian healthcare setting?
I think primarily it requires education at all levels, at the leadership level, at the clinician level, and at the patient level, to understand and appreciate the value that AI and continuous care brings compared to episodic care. With the absence of this information being known adequately by all these groups, adoption will not occur. It would be the responsibility, if I may dare say, of organizations like yourselves, DHN and Prodoc, to do this across the length and breadth of this country. It is not an easy task, but it is a task that has been seen in earlier days in various other situations. Technology, for example, was adopted in a similar manner and required pushing by various people in order that people accepted it. Similarly, this. However, what I can clearly say is that the ROI, the value add that artificial intelligence and continuous care will bring is enormous and would not have seen any precedents in the recent past. So I rest my case there, but I reiterate what you said: garbage in, garbage out. So we must make sure that all data is authentic, which is fed into these, and suitable regulation must be implemented. Thank you.
Right. Uh, we have heard the entire panel talk about the real value of artificial intelligence and where AI falls short, and what is the exact ROI at this, juncture from artificial intelligence.
Can I take
Asit
a
from
minute?
Sure,
Yeah,
sure.
sorry, but this is very interesting because I am tempted to say this. So the entire AI depends on the LLMs, and actually LLMs are based on the correct data. So you spoke about garbage in and garbage out. Now, one of the best case uses of AI is to prevent wrong data being entered. I'll give you an example because we are trying to experiment. So what happens is that, if you have wrong data, then it will not generate, clear results, and the entire
Hmm.
AI will go as a sham. So let's take example of a pin code. And pin code is very important in India, because through correct pin codes, what you can do is you can actually generate lot of things like disease pattern, the type of patient, HNI population. You can mix and merge that data, and that's very important. Because a lot of us in hospitals do that to generate reports and to understand
Hmm.
what type of patient, what profiles are coming to us. Now, generally, what happens is this pin code data is wrong at least 35 to 40% of time. Somebody just keys in any of the figures. So what we are trying to experiment is, we are trying to build an AI which will integrate with the HIA system, and whenever any wrong pin code is being you know is being fed, it will actually give a uh, box. It will actually give a flag that, this is a wrong pin code, and it will not accept. So
Hmm.
this is one example how AI can, it's of course a cycle, but how AI can also be used to prevent mistake proofing, and
Correct.
actually build better LLM. So this was, I think, relevant. So I took this 1 minute to speak about this.
No, that's a fantastic use case of artificial intelligence. And one of the major factors, where data goes wrong is also these minor errors in data entry. The clinicians are so overburdened that they are not able to, focus on the quality of the data that is being fed. And so is the case with, the paramedics, the nursing staff, and the others, right? So I think this is something where AI use case sounds absolutely fantastic. Asit, let me come back to you. We have heard our clinician voices, the operator voices. Tell us from your lens, from an innovator's lens, can you walk us through one concrete example of how Prodoc AI is helping hospitals reduce drop-offs or improve adherence? What has changed, and most importantly, how was it measured?
Perfect. So, had this question been in any other forums, and most of the forums that I've earlier spoken, it is very easy to give the benefit post discharge, right? Follow up, kar lo, next follow up kya hai, and stuff like that. But I mean, I was just going through the data for the hospitals that we have engaged. One very great example that we have is pre-operative care, right? Just by an AI scribing, a surgeon now advises a surgery to a patient. Automatically, what we can do is we can create a personalized patient journey. What this will now do is it will create and capture every milestone. It will kind of give timely reminders to the patient in terms of which are the blood tests, what is the next ECG follow up, and everything that is required pre surgery. So at end of the day, if you look at most of the hospitals are trying to see जल्दी से discharge करो, it should not take most time, उसके बाद follow up करो. Even if you are able to create a pre-operative care, right? 30% of the surgeries are done on time, right? There are no last minute, what do you say, postpones, and this brings a lot of value for a hospital, for a patient, and it all. I mean, if there was some important test which is missed out, that golden hour is lost during a surgery. So,
Hmm.
if we are able to bring this value, and we have seen just by using AI in pre-operative care, we have been able to reduce 30% reduction of, I mean, timely postponement, what was happening in the OPT commencements. So this is a great example that you can have with the AI.
Right. Thank you. Thank you so much for that. With that, we move into the last segment of today's discussion. I would like to ask one question to all of the panelists, and I would like you all to respond in just one sentence about the same. Let me start with Mr. Mahendra Palaji. In one sentence, what is the single biggest priority for Indian hospital leadership to get ready for a continuous AI powered care, according to you?
So again, are you able to hear me? Yeah.
Yes, yes, sir.
Yeah. Again, this would be again in the. I will be talking to you on this lens of cancer care only. Okay. So when I think about this future leader of oncology hospitals, I think there are three things which has to be aligned simultaneously. One is yeah, complete clinical understanding, leadership have means the fair knowledge of patient pathway. You can hide data influences, and you should speak data. And third is about human empathy, all in the same thread. So not one, two, but all of them in the same thread. And further to this, only two statements I would like to add. One is leaders going forward. Leaders must own they should co-own the clinical outcomes, not only the financial ones. And also, apart from participating in the boardrooms, I think they should also be very active, actively participating in the tumor boards as in this era of AI. That's what my take would be on this.
Right. Dr. Bajaj?
Yeah, I think the priority going forward is that we as healthcare leaders, I think all of us need to invest as much in clean data, interoperable systems, and clinical workflows as we do in buildings and medical equipments, because that is all we think about when we are thinking of setting up a new hospital. I think, as it was pointed out, that all of this needs much more attention now. And as Asit said, I think right now most medical leadership is limited to information in terms of what we get from our HMRs, from our dashboards. So we are getting a lot of information. We need to use the technology to go from information to insight to developing exactly what is going on, and then in an ideal scenario from insight to foresight, that we should know exactly what will happen with our patients and our hospitals next month, next quarter, next year, next decade. That is where we need to go now.
Right. Mr. Saurabh?
Yeah. So I think two thoughts. So first is work towards getting the data right, because if the data is not correctly captured, then the entire model or LLMs or whatever AI you put it will not work properly. That's one. The second thing is we do not have any more liberty to have parallel systems. And what I mean to say is when we started with digitization of healthcare, we used to have a parallel system of manual, data entry also, because something is not working or something is not talking, systems are not talking to each other. That liberty is no longer there. So you need to learn from, what mistakes, others have done, even globally, not just in India, and put the systems right in first place, because we do not have, second chance. The systems need to work right on day one. Otherwise, there is no, because the moment they say, oh, system काम नहीं कर रहा, अभी manually कर देते, your system will fail. If it does not work on day one, it will not work, and there will be dual systems and lot of, non-value add in the system, which will again reduce the time taken for patient care, and people will be more into, administrative task and data generation. So those are my two thoughts.
Right. Very valid point, sir. Dr. Shashi Pawar?
Yeah, hi. Am I audible?
Yes,
Yeah.
yes, you are.
Yeah. As you said, the question right, the biggest priority for the Indian leadership, which I believe, I think most of the speakers have already said for the AI powered care is the data readiness and the interoperability, because we have a lot of unifying, the fragmented health records as of now, not a central platform, as I said, for a digital this thing, so that the input goes to the AI. But same time, we need to be also ready to upskill our own staff, the paramedics, the doctors also with this kind of an AI tool, which is going to enable them for a better patient care. And as well as the, not to forget is something called the governance and the legal compliances which will come along with that. So that readiness definitely is what has to be there. But also, I would like to emphasize the more key point here is AI is not going to replace a doctor or the care provider. It is going to augment it. It is going to help it. So that has to be kept in the mind. Should not dispel that out. Okay, now the AI doctor is going to take care. Okay, no, but physically, the human touch, the empathy still will, which I believe will overpower what is required. Because if I say, look at my cardiologist when he is consulting a patient, the patient says that, okay, I spoke to you, you had examined me, now 80% I feel better, 20% just write a prescription, I think I'll be more better. So that is where it will come. It's not only the technology which will help. Yes, it will augment it. It will try to speed up the processes for us. But yes, we have to be ready in terms of not to lose the patient touch at all. That has to be taken into account.
True. The AI should not interfere between the sacred patient and the doctor relationship. I think that's the takeaway
Correct.
from your parting thoughts, Dr. Pawar. Dr. Jairam, your closing thoughts?
My closing thoughts, since you said one sentence, I'll stick to one sentence and one sentence only. AI powered EMR in each and every hospital of this country should be mandated and implemented. This will be the single propelling force to drive continuous care in the appropriate form.
Absolutely. Thank you so much, sir. And Asit, I come to you for closing of this session. From an innovator's lens, what are your closing thoughts on today's panel discussion and the question?
Thank you. This is amazing. So, for me, system of records to system of actions. We all are talking about data. The data is already there. The data is there in the IVR recording. The data is there with every lab test. Imagine there are 100 engagements for a hospital. And just being able to point out there were 70 surgical inquiries, and those are attended very differently. The data is there. If there is a data for a test that is being done and which is very abnormal, can we trigger a preventive healthcare checkup for him? So, what is important is how can we make the existing data? I understand recording of data, AI scribing is all there, but there is enough data that is already there in healthcare, and can we make it from a system of records to system of actions? And the biggest achievement for everybody, be it the technology, the clinician, the healthcare provider, is going to be that when we all talk about the post basic fundamental, that is prevention is better than cure. And that is the main theme of just the episodic, then creating the lifetime value, the life time health providing care that every healthcare provider can give.
Absolutely. Well, that brings us to the end of this very rich, no holds barred conversation on where continuous care actually stands today in Indian healthcare and where artificial intelligence can genuinely take it tomorrow. Thank you so much to all of our incredible panelists for their candor and to all of you for joining us. This conversation, again, as we all agreed here, does not end here, it just gets started. Thank you so much, all, for joining us here today. See you again.
Thank you.
Thank you.
Thank
Thank
you.
you very
Amazing.
much. Bye.
Everyone.